Okay, so the lumbar spine can be one of the most challenging body regions to evaluate accurately and provide precise and targeted interventions that are most effective. Yet, at the same token, we know that the prevalence of it is extremely high, over 80% within the lifetime of at least the Western hemisphere. And so, in hopes of consolidating a lot of the information that we talk about and within the actual live lecture and presentation, I wanted to orient you to the lab manual. This is intended to be kind of your go-to resource for clinical application of the concepts that we discuss within the actual live lecture. So the lumbar evaluation lab manual updated this year, that is of 2023. You can see on the left-hand side that I've provided uh, bookmarks that would allow you to quickly navigate the document compared to maybe a long PowerPoint presentation. So the table of contents, so you have the physical therapy diagnosis and what that entails. We'll talk about that in detail. The proposed framework for diagnosis, the lumbar evaluation workflow, which is built out in kind of a decision tree, if you will. And then we have an algorithm of the spinal evaluation where you can be selective in determining which assessments and evaluations that you actually incorporate. We talk about some additional like subcategorization and assessments and workflow tree with low back pain and leg pain and how you discern and differentiate between nociceptive, neuropathic, and centralized pain. We talk about the mechanical versus chemical inflammatory back pain symptoms and presentations. I have a postural assessment checklist that I think that will be at least somewhat beneficial in providing structure rather than just the abstractness of what is the evaluation of someone's posture, that being static and or dynamic. I provide the lumbar evaluation template, which you'll see, and this is intended to be something that you could even print off and use as a documentation tool and to allow you to quickly visualize all arsenal that you have from an assessment standpoint and be deliberate and selective in your triage of someone who presents with low back spinal pain. We talk about the neurological assessment in detail, why you would not be guessing whether this would be indicated or not, why you would not be guessing as to the specific dermatomal points, and we really emphasize the utilization of the Asia key sensory points as they have shown to have the highest predictability of being an accurate dermatome for a given level based off the tens and hundreds of thousands of people that have gone into determining those points. We talk about the physical examination and tests on a very high level. It just really is more of a checklist here for you. And then I also provide an appendix, which gives us a physical exam diagnostic fillable form. So let's get to it. So, what goes into a physical therapy diagnosis? Again, we'll go into this in detail within the actual lecture, but I would say that a physical therapy diagnosis is often quite abstract for a lot of young clinicians. And I have yet to find a better definition than the one that is shown here with the 4-point framework. Proposed framework for the diagnosis would include all of the following: tissue source, which is pathoanatomical tissue or pathobiological pain mechanisms; the tissue stress, the physical stress that elicits the symptoms from the tissue source, listed at number one; the movement faults, so it has an element of a movement analysis. The movement fault is usually the movement or movements that cause or induce the stresses that cause and elicit the symptoms from the tissue source. And then, consistent with the clinical practice guidelines of the APTA, the ICF classification. And I've provided further detail as well as hyperlinks to certain references that you can look up based off why these four are selected. But I think that it's comprehensive. It it's informative to you as the clinician and your future self as to where you go with this patient. It's informative to the patient themselves that actually have a working understanding of what they're coming in and what's causing their symptoms. And then it also allows for succinct communication with other healthcare providers. And as I also alluded to with a lot of the treatment-based classifications and clinical practice guidelines, it helps to determine your treatment course. Next is the lumbar evaluation workflow. And this has been one that has been ongoing for me in its evolution and its development. So I imagine that it may continue to evolve as more information becomes available over the coming years. But it is my current mental framework, and one that I would encourage you to at least adopt or uh, marionette and integrate into your own mental framework that you're currently utilizing within your clinical practice. So you have the decision-making triage that is endorsed by the APTA and the Physical Therapy Journal with the treatment-based classification. Is this person even determined to be appropriate for physical therapy, medical, and that would yes would be the self-care management and or the rehab management. The medical management individual, is this someone who is inappropriate or is going to need additional multidisciplinary care? That would come really, at least from your mental model and your thin slice from reviewing their chart. You have the subjective evaluation, the hypothesis generation, and the potential tissue source, be it somatic, be it nociplastic, be it neuropathic, be it nociceptive. And then pattern recognition, and this falls into the clinical guidelines of the ICF classification. And one of five potential categories that it could that this individual's back pain could be classified in. And we know that there's a high proportion of individuals that would fit more than one category, but you're doing your best to try and identify what is their primary limiting factor. And then this would be further delineated and confirmed within your physical examination. And you have some decisions to be made here when you're transitioning from your subjective to your physical exam. Are you going to do a full or limited examination? Are you going to do a neurological examination? Yes or no? Again, it shouldn't be an emotional decision. It should be very clear cut. If any of these elements are either present or historically have been so, then a neurological examination would otherwise be indicated. Same with your limited versus full examination, trying to make it a clear and decisive decision point for you. And then what body regions should you also incorporate based upon their subjective evaluation? And this certainly could potentially evolve throughout the physical exam, depending on what certain findings are. And so you're consistently using an algorithmic rule in, rule out mentality as you move through the examination. The next resource that feeds off of the workflow above is further helping you to determine whether they are mechanical, chemical, and inflammatory based upon their symptoms, and or a combination of mechanical and inflammatory. I give some descriptions of each as well as the symptoms. The next is the lumbar spine physical examination algorithm. So this is really just breaking out what is that lower half within the workflow. So if we jump back for a moment to the evaluation workflow, we're now like breaking this out. What does that entail? And that's what you see here with the algorithm. So you're going to run your primary physical examination component, and then based off indication or additional findings, then you would jump to your secondary. But your secondary would only a sub cohort of individuals would be appropriate for the ones that you see on the right hand column. And then we've organized it based off feedback that we've gotten previously from young clinicians, and I also think just from an efficiency flow is going from standing, seated, supine, and side lying evaluation, followed by prone and any other additional assessments that may be indicated. Here's the checklist that I was talking about with the postural assessment. We talked about looking from a top-down or potentially a bottom-up approach, depending on how you're going about your spinal assessment and postural assessment. And we will also say that current technology is advancing such that we will very soon have technology to help us better delineate and fine comb our assessment of someone's posture, not only static but also dynamic. And so I have provided a checklist, the green check marks being that of the ones that are considered to be ideal, or by ideal, I specifically mean that they are often associated with putting less concentrated stress on certain body tissues and thus may be less associated with someone's symptoms. But we will talk about in detail about the causation and correlative relationships that posture, at least static posture, has with symptoms and disability. But this provides kind of a full gamut and full stop checklist for what am I actually looking at when I'm looking at someone's posture, because it can often be a bit vague and a little bit difficult when first starting out. Okay. And then for those individuals where neuroscreen would otherwise be indicated, or those that have back pain with associated leg pain, and you're trying to discern whether this is somatic referred, be it a sclerotome, be it neuropathic, be it radiating, being it referred pain, and so on and so forth, then this algorithm has been really helpful for me. And so we can use the Lane score, we can look at neurological deficits or insults and function within our assessment. And then we have our nerve trunk mechanosensitivity with peripheral nerve sensitization and musculoskeletal referred pains and symptoms. And so I would encourage you to take a look at this before the actual live assessment and continue to do so even afterwards as you continue to try and differentiate the pain mechanisms that your patient is presenting with. Same differential with just a further diagnostic grouping in the first column than what you saw above. I like the one above because it gives you a sequential workflow rather than just a list of information as this one does, but I think that it can still be informative, especially when combined with the workflow that you saw on the previous page. So again, look through this in detail. I found it to be quite helpful to discern someone's most likely contribution of their symptoms. But again, it's not going to be an all or none. Oftentimes, unfortunately, there is some gray, but what is the predominating factor and what is your evidence for and against your differentials? You can see that I've added a third one, third resource as well, because that's for me, it's just been helpful. And so in my own struggles, I've provided, these are the resources that have been fruitful for me as a young clinician, even as a seasoned one, as I continue to learn and get better at assessing and being a diagnostician. Perhaps they will also be helpful for you. So it will expedite your rate of improvement and expertise. So those final three again are just trying to help you discern the though be appropriate for those individuals that come in with either neurological complaints or sensations or pain descriptors, and or that have back pain with associated leg symptoms. This is a document that I consider to be hopefully a relatively powerful document for you. This is one that has evolved with me, that I was self-generated from even my first MSK class in DBT, and I've continually to adapt and evolve it through my clinical rotations, through my residency, through my fellowship, and then also through my current independent clinical practice over the last several years. And really what what I've tried to do is that in each of the different structured educational settings that I've been in, is that I found that clinicians and or teachers or instructors have consistently presented a different lumbar and or any body region for that matter evaluation sequence. And so rather than falling subject to a recency bias or falling subject to cognitive bias of a workflow that was most succinct or most conducive or that I was most comfortable with. I've found it valuable to have a full gamut and full stop of all the potential validated and reliable assessments that one could consider when trying to diagnose and provide a physical therapy diagnosis to someone presenting with low back spinal pain. And so here's the product there within. And so we have the different body region, the different standing postures, sitting postures, supine. So it follows like almost like a column flow, similar to that which was above in our workflow, but this is intended to be potentially even printed off and used as a guide within your patient encounter where you could actually take notes and jot down the findings that you foresee that may help to better discern the pattern that the patient is presenting with. And then the hyperlinks here, so you can, I've done an annotated bibliography. So what, let's use an example. So for instance, I use Faber, and so I can double click on this. That will take me immediately to the reference list, and then it will show the actual reference, and it will also hyperlink to that. You can see in other hyperlinks within this same document, for instance, the functional tests, that I've also not only provided references with hyperlinks, but then it gives you the specific testing positions, the norms for each test, and then the ideal ratios for the functional endurance test. And then we can double click on the reference to just jump us back to where we were. The second page here is intended to be the back side of the above page. So a two-sided piece of paper that, again, has almost like full stop things that you need for your evaluation patient encounter. You have the red flags that are referred from the low back, and you have red flags that are referred to the low back. You have your ICF classifications based off the clinical practice guidelines, as well as the different criteria that would lump or be most consistent with individuals that would fit this particular group. And then you also have diagnostic clusters that have been described. Okay, these next two pages are simply additional diagnostic clusters that exist. And this comes from the Vining article, and it's also part of the appendix. But this can be, if you're trying to better discern like what is the pathoanatomical diagnosis, then this can be pretty helpful, especially because as healthcare providers in general, we're pretty poor at identifying the pain generator within the low back. Hence the title, non-specific low back pain, which is, in my opinion, unacceptable. If we use that same methodology within another body region, I think that it would be quite laughable. For instance, let's use the example of leg pain, like non-specific leg pain. That could be everything from shin splints to an ACL rupture. Yet we still lump the low back pain with non-specific low back pain into the same exercise category. Whereas with the leg, shoulder, arm, etc., we are much more specific. And I would encourage us and challenge us as a profession to be so, because I think it provides better, higher quality care and allows us to be a better asset to our patient and to humanity on the whole. So I'll have you look through these at your leisure and independently. But again, the importance of and purpose of this video is to give you a high-level overview of what it all entails. Co-management approach for comorbidities that patients with low back pain present with. So for instance, physical comorbidities associated with low back pain, right? So if they have arthritis, cardiovascular conditions, etc. Tools to identify such comorbidities and the descriptions of the tools. So if you're not really sure based off your subjective and your physical examination, then these patient-reported outcomes and other tools can be quite helpful in discerning additional supplementary care as well as multidisciplinary care for your patients. These final couple slides incorporate the movement assessment as well as the neuro screen. And so we have our checklists for what we're looking for when someone starts to go through their functional spinal motions. On the left hand, you have that from from like the Shirley Sarman in movement science or movement impairment approach. And then you have the SFMA breakdown on the right hand side of the screen. You can use a combination of either or select one. I think regardless, both schools of thought would encourage you to be consistent in your evaluation because the more consistent you are, the more sensitive you will be to the nuances of deviations that the patient is presenting with. That being said, if you were consistently changing your physical exam, it's very difficult to pick up on particular patterns over time. We talked about the qualsis of the single leg stance and how you could start to objectify this and not only use it as a reliable test and post-test. So this is just written out for you as an additional resource. The neurological assessments for the upper and the lower extremity, the indications, the myotomes, the dermatomes, again, the Asia key sensory points shown there. And then just a high-level overview checklist of the physical examination and tests that we discuss within the live lecture, as well as the potential assessment outcomes. Again, the sheet is friendly to potentially print off if you're still wanting to go through the steps and really become more more consistent with them over time. Sometimes that's a helpful practice, but obviously not necessary. The purpose of the overall document is that you are that it just summarizes and allows you to translate the information within the larger PowerPoint into clinical friendly tools and utilities and quick references. All right, and here's the appendix as I mentioned, and then finally references. All right. I hope that you find it valuable. Please let me know if you have any comments, questions, or concerns, any constructive feedback of how we can make this resource even more helpful for you in your clinical practice, not only within the residency, but moving forward and or beyond the confines of the course. I'm all ears. Certainly want to give you the very best opportunity for success with your low back pain patients.